Hey, good morning. Welcome to Friday and episode 11 of Bipolar and Me. I'm Anne. Welcome back. Today we are talking about the medical bias of providers with the psychiatric patient. I've been seeing that kind of resurging on social media as a new theme, and it's something that I tackled a few years ago in a guest post for another blog. And I think it's kind of timely to revisit that, frankly, because that medical bias actually can do a lot of harm. And if we don't recognize it and we don't treat the psychiatric patient properly with their actual physical concerns, harm can be done and patients can actually be killed. And it's so stupid that I have to call it a physical ailment, because this is your brain. It's a physical organ. It's all physical when it comes to what we're talking about at the end of the day. I just had this conversation with my consulting psychiatrist I work under yesterday. It's all physical in the end. Brain's an organ just like anything else. But for some reason, there's this inherent bias with other providers when they have the psych patient present to their office, to their ER, to their urgent care clinic, and they see these diagnoses all on the paperwork. So they're like, oh, they're not really sick. They're a psych patient. But that's not true. They're sick. They have needs. There are other organs in their body that act up and flare up just as much as the brain does, and we have to take them seriously. I want you to think about, say, a patient who presents to their local emergency room at the prodding of their spouse while experiencing, let's say, 36 hours of mid-sternal chest pain that's just been aggravating them. They've done the usual, taking aspirin, they're having trouble taking a deep breath. It's not relieved with antacids or aspirin, and they feel worse when they're moving around. So they go to the emergency room, they're checked in, they get an EKG, and they're sent back to the waiting room and wait, and wait, and wait, and wait, and wait, and wait, and wait. After a few hours, a polite inquiry is made as to when they might see someone, knowing that chest pain is usually considered to be a serious malady. They're told their EKG is normal and that they will be seen as soon as possible, and they're waiting for a doctor to come speak with them. Frustrated because, 4 to 5 hours have gone by, they leave. They make an appointment with their primary care doctor, who diagnoses them with costochondritis, which is an inflammation of the cartilage of the ribs. And it can mimic that of a heart attack, the pain that they're having. It's easily treated with a 2-week course of a non-steroidal anti-inflammatory medication, something that we think of as like ibuprofen or naproxen, but they give them a little bit stronger one. But the medical record shows that the patient was seen for a primary problem of anxiety, secondary problem of chest discomfort. Nowhere at any point was the patient anxious. They had chest discomfort, and they just wanted to know what it was and why it wasn't relieved with traditional remedies for chest pain. I'll give you this scenario. Patient presents to a neurologist who specializes in the treatment of migraine at the behest of their other providers for better management of those migraines. Weren't very well controlled. On the day of the appointment, the patient is in the waiting room with a migraine, light sensitive, throwing up in a trash can with a prolonged waiting time. When they are finally seen by the neurologist, they were told that the migraines were made up, being used to get attention, and that it was all in their head and not real. They left without medical care. In fact, they were actually told, oh, you're one of those bipolars. Outrageous, right? In today's day and age of medicine where patient satisfaction rules, how dare someone's chest pain be ignored and they find out that they were viewed by the provider as anxious despite an actual medical condition being diagnosed, how could a neurologist tell a patient who's vomiting from a migraine that this is a made-up attention-seeking headache? What if I told you, oh, I already gave it away. I was going to say, what if I told you both patients' charts carried a diagnosis of bipolar, but I already gave you that away on one of them. I got ahead of myself. In the advent of electronic medical records, providers are fairly savvy on the patient's medical condition and past histories before they even see these patients. So therefore, they're able to make up these judgments and biases before they even see or lay eyes on the patients and do a thorough medical history and examination. Are you still outraged? I hope so. Hold on to that for a minute. I was intrigued by this bias of the seemingly different standard of medical care as it appeared it was being offered to a patient with a pre-existing psychiatric diagnosis versus one who didn't have one. So, for example, the chest pain differential, once the EKG was done, ruled out changes concerning for the heart attack. It's still long and warrants workup. Fortunately for our patient, it's okay. But imagine if they return 24 hours later in extremis. It is still baffling how at no time their PCP found a primary episode of anxiety necessary when they were calm, stated the facts of what was happening to them perfectly reasonably, and this anxiety diagnosis was necessary versus the costochondritis the patient was treated for. The migraine patient was to agree with the neurologist with the words, "Oh, I see you're bipolar." Well, that's not really politically correct. It should have raised red flags from the neurologist because that the patient has headaches, since migraines are a proven comorbid condition of bipolar disorder, not suggest that the patient was confabulating a disorder and wasting their time. Did the patient make up the vomit in the trash can in the waiting room too? That's kind of hard to do. I know these two anecdotes and situations presented don't even begin to scratch the surface of what psychiatric patients experience while trying to obtain medical care. I did a lit review in an attempt to grasp, the extent of the problem, and not entirely unsurprising. At the time I was able to find much, but I did learn a lot of information. In 2013, these four people, Mena, Bichon, Rigoretto, and Salvi, noted that those with bipolar disorder have worse physical health and life expectancy reduced by about 30% compared to general population. We tend to think about people with severe bipolar disorder as living about 20 years less than the average person. Take Carrie Fisher, for example. She died at age 60 of a massive heart attack, while compliant with care. While age 60 compared to age 80, in theory, she was kind of right on time, which is really, really sad. So, Mena, Bichon, Rigoretto, and Salvi, they found patients with bipolar disorder are more likely to have cardiovascular conditions, hypertension, diabetes, respiratory illness, liver dysfunction, and peptic ulcers. 55% of the patients they examined had a comorbid condition. The most common ones being endocrine or cardiovascular, which is no surprise when you look at the data of the drugs that bipolar patients take. 64% of the patients who had an endocrine disorder experienced metabolic syndrome. The biggest risk factors they found that predicted a risk of a comorbid condition were female gender and duration of untreated illness. It was noted that individuals with bipolar disorder were more likely to demonstrate risky behaviors health-wise in terms of diet, poor exercise habits, suboptimal self-care, limited access to healthcare, and perhaps an unwillingness to obtain healthcare during periods of depression. You can believe that. It was also noted that the medications used to treat bipolar disorder and thus are lifetime medications. I'm on my medications for life. I know that. I'm sticking with them because I am well and I am doing well. So thus down the hatch every day for the rest of my life they will go. But they place patients at risk for obesity, metabolic syndrome, and thus cardiovascular disease and diabetes. It's a risk I have to take. This data I mentioned was taken from an article in this journal called Psychosomatics back in 2013 for anyone who's interested. You know, you can also find similar data from a journal article in JAMA Psychiatry 2013, 2014 articles, and it just keeps getting better. You'll find now that as time marches on, you'll find it in 2018 journals, 2017 journals. You know, it's not just old data anymore, it's current data. I went to a conference where now people are talking strictly about cardiometabolic syndrome in patients with serious mental illness because of their medications. So really it's worth noting that this bias exists. It's worth noting that primary care providers have been shown to hold a more stigmatizing attitude than other providers. And who's your gateway keeper for everything you do? Your primary care provider. It could be hypothesized that the same set attitude carries over to other providers of a non-psychiatric specialty. However, the paucity of data and the lit review that I did at the time, I don't have an answer for you for that. But what I do know is patients with a psychiatric diagnosis deserve better care, and we need to stand up for ourselves. We need to take matters into our own hands and be our own best advocates when it comes to our medical care. I've learned to do that. I've learned to, because of the weight I had gained due to my medications, and I looked up the psychiatry studies about weight gain and metformin, I brought them all to my primary care doctor and I said, hey, are you willing to try this with me? Here's 4 articles I brought for you. She said, I've never done this before, but let me read them and yeah, let's do this. It's being our own best advocates is how we get to a good state of health. And I strongly encourage any of you out there to do that, to do the research. Yeah, it sucks, but if we don't do the research, who's going to do it for us? And who's going to take care of us? No one. We have to. Our providers are part of a team, but you know who's the other integral part of that team? You are, just like I am for my team. We deserve the same standard of health care as anyone else. We ask for and expect parity with our insurance, and it's reasonable that that very parity it would extend to our medical care. The data clearly shows a collective that we hold a higher risk of cardiovascular disease, endocrine disorders, stroke, and risky modifiable behaviors. So there's no reason any one of us should hold increased mortality versus the general population. We just need to take equal responsibility for it as our provider should. So if we sit down, pay attention, and have these talks with our providers and hold them accountable to the biases that they may have, we can do well. So stand up, speak up, and empower yourself to take care of yourself and fight against this medical bias. That's all for today. I'm Ann. Thank you so much for tuning into Bipolar and Me, and I can't wait to see you next week on Monday. Thank you. As always, like, share, subscribe. See you soon.